What I'm about to share may completely change how you understand cholesterol and stroke risk. At this very moment, millions of older adults are worrying about the wrong cholesterol number. Many are taking medications they may not truly need. Others are avoiding foods that could actually be protecting their blood vessels. They're living in fear of a number that has little real connection to stroke, while overlooking the one that signals serious danger. As a cardiac surgeon with more than 20 years of experience operating on stroke patients, this is deeply troubling to me. The cholesterol marker that truly drives strokes, the one that can predict whether someone may wake up unable to speak or move one side of their body, is already listed on a standard cholesterol panel. Yet the vast majority of seniors have no idea which number it is or why it matters. Over the years, I've seen the consequences up close. I've removed clots from brains where blood flow was suddenly cut off. I've opened carotid arteries in the neck that were nearly completely blocked by hardened plaque. I've held brain tissue that died because cholesterol-filled clots stopped circulation. These experiences reveal what actually causes strokes at the most basic level. Despite this, most people are still told to focus almost entirely on LDL, often labeled as bad cholesterol. They're advised to lower it as much as possible, take statins, avoid saturated fat, and do whatever it takes to drive that number down. However, the scientific evidence tells a very different story, especially for people over the age of 70. In this group, LDL cholesterol is a surprisingly weak predictor of stroke risk. There is another number on the same cholesterol test that predicts stroke risk with far greater accuracy. Yet almost no one talks about it. By the end of this video, you'll understand which cholesterol marker truly matters for stroke prevention and why. You'll be able to interpret what's happening inside your arteries based on your own lab results. You'll also learn the target ranges that are most strongly associated with a lower risk of stroke. Most importantly, you'll discover why the medication you were prescribed may not be the most effective approach for preventing a stroke. It's critical to stay until the end, because there's a specific cholesterol ratio I'll explain later that predicts stroke risk better than any single cholesterol value. Shockingly, almost no physicians calculate this ratio or discuss it with their patients. If you miss this part, you'll keep paying attention to cholesterol numbers that don't truly matter, while overlooking the ones that actually determine stroke risk. To explain why this is so important, let me share a real situation from my practice. Last year, on the same day, two women came into my office. Both were 73 years old, and both had just received their cholesterol test results. On paper, one appeared far more concerning than the other. One had cholesterol values that immediately triggered alarm, while the other seemed comfortably within what most doctors consider a safe range. The first patient was placed on aggressive medication right away and instructed to drastically change her diet. She left my office frightened, convinced a heart attack or stroke could happen at any moment. The second patient was reassured. Her doctor saw nothing urgent, told her everything looked fine, and suggested a routine follow-up the next year. What happened next tells you everything you need to know about cholesterol and stroke risk. 18 months later, the patient who had been labeled high risk remained healthy, with no cardiovascular events at all. The other woman, who had been told she was doing fine, suffered a massive stroke just 6 months later. She survived, but she lost her independence. She now struggles to walk without help and has severe difficulty speaking. The reason for this difference had nothing to do with LDL cholesterol. In fact, the woman who stayed healthy had a higher LDL than the one who suffered a stroke. The real issue was hidden in other parts of the cholesterol panel, numbers that are frequently ignored. One patient had protective levels of beneficial cholesterol and healthy triglycerides. The other had dangerously low protective cholesterol and extremely high triglycerides, a combination that signals severe stroke risk. Her lab results were clearly warning of danger, but those warnings were missed because only total cholesterol and LDL were considered. That oversight cost her quality of life and independence. Before I explain which specific cholesterol marker is most closely linked to strokes, it's essential to understand what these numbers actually represent. Cholesterol itself is not the enemy. It's a waxy substance your body depends on. It plays a vital role in building cell membranes, producing hormones, and synthesizing vitamin D. Problems arise when certain types of cholesterol circulate in unhealthy patterns. Under those conditions, cholesterol can accumulate inside artery walls, forming plaques. Over time, these plaques narrow the arteries and disrupt normal blood flow. Even more dangerous, they can rupture suddenly, triggering blood clots that completely block an artery. When a clot blocks an artery supplying the brain, the result is an ischemic stroke. Brain tissue beyond the blockage is deprived of oxygen and begins to die within minutes. This process is what leads to paralysis, loss of speech, and long-term disability. It's important to understand that roughly 87% of all strokes fall into this category. The remaining strokes are caused by bleeding in the brain and involve different mechanisms and risk factors. For the remainder of this discussion, the focus is on ischemic strokes, the type driven by cholesterol-related plaque and clot formation. Cholesterol does not move freely through the bloodstream. It travels inside particles known as lipoproteins. LDL particles transport cholesterol from the liver to tissues throughout the body. HDL particles, on the other hand, play a very different role, one that becomes critical when assessing true stroke risk. These particles carry excess cholesterol away from the bloodstream and back to the liver, where it can be processed and eliminated. For decades, cholesterol has been divided into simple categories: LDL labeled as bad, HDL labeled as good. The idea seemed straightforward. Higher LDL meant more cholesterol building up inside artery walls. Higher HDL meant more cholesterol being cleared away. Lower LDL, raise HDL, and the risk of heart attacks and strokes would automatically fall. However, research over the past decade has shown that this model is far too simplistic, particularly when it comes to stroke risk, and especially in adults over the age of 70. Large-scale studies now demonstrate that LDL cholesterol is a relatively weak predictor of stroke in older populations. In other words, LDL levels alone tell us surprisingly little about who will actually suffer a stroke. One major long-term study followed more than 20,000 adults over 65 for 10 years and found that LDL cholesterol had very little association with stroke risk once other factors were considered. Individuals with LDL levels in the 160 range did not experience significantly more strokes than those with LDL closer to 100. In contrast, two other markers stood out with striking consistency: HDL cholesterol and triglycerides. Low HDL levels were strongly linked to higher stroke risk, and elevated triglycerides showed the same pattern. The researchers concluded that focusing primarily on LDL for stroke prevention in older adults is largely ineffective. Despite this evidence, many clinicians continue to center treatment decisions on LDL cholesterol. Medical training evolves slowly, and there are powerful financial incentives tied to medications designed to lower LDL. As a result, the most relevant risk markers are often overlooked. The cholesterol-related factor most strongly associated with stroke in seniors is low HDL cholesterol. This is the critical takeaway. When HDL drops below 40 in men or below 50 in women, stroke risk rises dramatically. Compared to individuals with HDL levels above 60, the risk increases by roughly 60 to 70%. Those numbers are not subtle, and they deserve attention. Low HDL contributes to stroke risk because HDL does far more than transport cholesterol. It plays a protective role throughout the vascular system. HDL reduces inflammation within artery walls, limits the oxidation of LDL particles, helps remove cholesterol from existing plaques, and influences blood clotting by regulating platelet activity and clotting factors. When HDL levels are low, these protective mechanisms weaken or disappear entirely. Without sufficient HDL, arteries become inflamed, LDL particles are more likely to oxidize and lodge in vessel walls, plaques grow larger and more unstable, and the blood becomes more prone to clotting. Each of these changes independently raises stroke risk, and together they create a dangerous environment inside the arteries. Low HDL is especially common among older adults, particularly those who are sedentary, overweight, or living with diabetes or metabolic syndrome. Millions of seniors have HDL levels in the 30s or low 40s, yet this is often ignored because attention remains fixed on LDL. Meanwhile, that low HDL quietly raises stroke risk by more than 50%. Triglycerides represent the second major cholesterol-related predictor of stroke. Triglycerides are a type of fat found in the blood and are measured alongside cholesterol on standard lipid panels. Elevated levels, especially above 150 and more so above 200, are associated with a substantially higher risk of stroke. People with triglycerides above 200 face roughly 40% greater risk compared to those with lower levels. High triglycerides increase stroke risk through several mechanisms. They are linked to smaller, denser LDL particles that penetrate artery walls more easily and form plaques more efficiently. They often signal underlying insulin resistance and metabolic dysfunction, both of which promote inflammation and abnormal clotting. At very high levels, triglycerides can even thicken the blood, further increasing the likelihood of clot formation. Taken together, low HDL and high triglycerides are the two cholesterol-related numbers that matter most for stroke risk. Even more powerful, however, is the relationship between them. The triglyceride to HDL ratio provides a clearer picture of vascular risk than either number alone. This ratio is calculated by dividing triglycerides by HDL. A value below 2 is considered optimal. A ratio between 2 and 4 indicates moderate risk. A ratio above 4 signals high risk for cardiovascular disease and stroke. When this ratio rises above 6, stroke risk enters an extremely dangerous range. To understand how this works, it helps to see how the calculation is done. When triglycerides are 100 and HDL is 50, the ratio equals 2, which is considered optimal. When triglycerides rise to 200 and HDL drops to 40, the ratio becomes 5, placing someone in a high-risk category. If triglycerides reach 300 while HDL falls to 35, the ratio climbs above 8, indicating an extremely high level of risk. This calculation is important because it captures overall metabolic health in a single number. A low ratio suggests that the body is efficiently using fats for energy, insulin sensitivity is good, and inflammation levels are low. A high ratio points to metabolic dysfunction, insulin resistance, chronic inflammation, and a heightened tendency for blood clot formation. These are the exact conditions that drive strokes. Multiple clinical studies have shown that the triglyceride to HDL ratio predicts cardiovascular events, including stroke, more accurately than LDL cholesterol alone. Despite this, the vast majority of physicians never calculate this ratio or discuss it with patients because attention remains centered on LDL values. In my own practice, this ratio is calculated for every patient. When it exceeds 4, it signals a substantially elevated stroke risk regardless of the LDL number, and treatment is directed toward improving this metabolic pattern rather than simply lowering LDL. The reason LDL alone provides limited insight into stroke risk, especially in older adults, lies in how crude the measurement actually is. LDL cholesterol does not reveal how many LDL particles are present or what type they are. Two people can share the same LDL level while having vastly different particle characteristics. Some individuals carry larger, less harmful particles, while others have smaller, denser particles that more readily penetrate artery walls and form plaques. Standard cholesterol panels do not make this distinction, and advanced particle testing is rarely ordered. With advancing age, the link between LDL cholesterol and cardiovascular outcomes weakens even further. Research involving elderly populations has shown little association between LDL levels and overall mortality. In some cases, very low LDL levels in older adults have been associated with worse outcomes, possibly because cholesterol plays an essential role in immune function, hormone production, and cellular repair. Aggressively lowering LDL in this age group may offer limited benefit while increasing the risk of side effects. In practical terms, this means that treatment decisions should be guided by the full cholesterol pattern rather than a single number. Older adults with healthy HDL and triglyceride levels often have a low stroke risk even if LDL is moderately elevated. In such cases, aggressive medication may offer minimal protection while increasing the likelihood of muscle pain, cognitive complaints, or metabolic side effects. On the other hand, individuals with low HDL and high triglycerides may carry substantial stroke risk even when LDL appears acceptable, yet this risk frequently goes unaddressed. Medication choice is where treatment often misses the mark. Drugs designed to lower LDL are highly effective at doing exactly that, but they have only modest effects on raising HDL or lowering triglycerides. When the primary issue is poor metabolic balance, reflected by low HDL and high triglycerides, these medications do not target the underlying problem. Other therapies focus more directly on triglycerides and HDL. Certain medications are specifically designed to lower triglycerides and modestly raise HDL, making them more appropriate for individuals with this risk profile. Niacin has also been shown to significantly increase HDL and reduce triglycerides, though its use has declined despite ongoing debate among experts about its benefits in selected patients. Prescription-strength omega-3 fatty acids are another effective option, capable of meaningfully lowering triglyceride levels at therapeutic doses, unlike low-dose over-the-counter supplements. The key takeaway is that stroke prevention depends on identifying the right cholesterol pattern. The most effective treatment is the one that corrects the specific imbalance driving risk, not the one that simply lowers a single number on a lab report. The right treatment depends on the underlying cholesterol pattern. When LDL is elevated but HDL and triglycerides are within healthy ranges, medication aimed at lowering LDL may be reasonable. In cases where HDL is low and triglycerides are high, other therapies that directly address those imbalances can be far more effective. When HDL is specifically low, certain medications may help raise it. Unfortunately, many clinicians rely on the same approach for nearly everyone, largely because that is how they were trained and what is most heavily promoted. As a result, alternative options are often overlooked even when they may be more appropriate. This is why self-advocacy matters. If your test results show low HDL and elevated triglycerides, it's important to have a direct conversation about treatments that target those specific numbers rather than focusing exclusively on LDL. Medication, however, is only part of the solution. In many people, lifestyle changes alone can dramatically improve HDL and triglycerides, sometimes eliminating the need for drugs altogether. These strategies differ from the traditional advice centered only on lowering cholesterol. They are targeted interventions designed to improve the numbers that actually drive stroke risk. Weight loss is the most powerful lifestyle factor. Losing excess body fat, especially around the abdomen, has a profound effect on metabolic health. Even modest weight loss can raise HDL levels and significantly lower triglycerides. For individuals carrying extra weight, this should be a top priority. Physical activity plays a critical role as well. Regular aerobic exercise is one of the most effective ways to raise HDL. Higher intensity activities are particularly beneficial. Exercise that makes breathing heavy and limits conversation has been shown to meaningfully increase HDL over time. Strength training also contributes by improving insulin sensitivity, which helps bring triglyceride levels down. Dietary changes are equally important. Sugar and refined carbohydrates have a direct and powerful effect on triglycerides. When excess sugar is consumed, the liver converts it into triglycerides. Removing refined carbs such as white bread, pasta, rice, and sweets can lead to rapid and substantial drops in triglyceride levels. Replacing these foods with protein, healthy fats, and non-starchy vegetables is one of the fastest dietary ways to improve metabolic markers. Increasing omega-3 fatty acids through food is another effective strategy. Fatty fish naturally rich in omega-3 support healthier triglyceride levels and may modestly improve HDL. For those who do not consume fish regularly, high-quality omega-3 supplementation at adequate doses can offer similar benefits. Alcohol intake also plays a major role. Even moderate drinking can significantly raise triglycerides. Reducing alcohol or eliminating it entirely often leads to noticeable improvements within a short period of time, particularly in people with elevated triglyceride levels. Fat quality matters as well. Artificial trans fats negatively affect cholesterol balance and should be avoided entirely. Saturated fats have more nuanced effects and can be included in moderation, but excessive intake is not advisable for stroke prevention. Finally, fiber intake is frequently overlooked. Soluble fiber supports healthier lipid levels and improves overall metabolic function. Increasing fiber-rich foods such as legumes, whole grains, and vegetables can contribute to lower triglycerides and modestly higher HDL, especially when intake is significantly increased beyond typical levels. When these lifestyle strategies are applied consistently, they can transform the cholesterol profile that truly matters for stroke risk and provide protection that no single medication can achieve on its own. Increasing fiber intake plays an important role in stabilizing blood sugar and improving insulin sensitivity, which indirectly supports healthier cholesterol levels. Another critical step is quitting smoking. Smoking significantly suppresses HDL levels, often lowering them by 5 to 10 points compared to non-smokers. When someone stops smoking, HDL typically begins to recover within a few months. Beyond cholesterol, smoking directly damages blood vessels and independently raises stroke risk. When all of these lifestyle changes are applied consistently and aggressively, the results can be dramatic. Many people see their HDL increase by 10 to 20 points and their triglycerides fall by 50 to 100 points within 3 to 6 months. These shifts represent a major reduction in stroke risk. For some individuals, lifestyle changes alone are enough to normalize cholesterol patterns without medication. However, this requires full commitment. Partial changes rarely produce meaningful results. Eliminating sugar and refined carbohydrates completely, exercising regularly at a challenging intensity, and achieving real weight loss are essential. These changes are difficult, but living with the aftermath of a disabling stroke is far more difficult. There is another cholesterol-related marker that deserves attention because of its strong link to stroke risk, yet it is often overlooked. This marker is lipoprotein A, commonly referred to as LPA. It is a genetically determined form of LDL that is inherited and remains relatively stable throughout life. Elevated LPA is highly atherogenic, meaning it promotes aggressive plaque formation in the arteries. Levels above 50 milligrams per deciliter are associated with a substantially higher risk of both heart attack and stroke, with some studies suggesting a 30 to 40% increase in stroke risk. LPA is not included in standard cholesterol testing and must be ordered separately. Many clinicians are unaware of its importance and therefore never test for it. Individuals with a strong family history of early cardiovascular disease or those who experience events despite otherwise normal cholesterol levels should consider having this marker measured. There are currently no effective treatments that significantly lower LPA. Common cholesterol medications have little to no impact on it, and lifestyle changes offer minimal reduction. However, knowing that LPA is elevated allows for stricter control of all other modifiable risk factors. When genetic risk is present, blood pressure, blood sugar, HDL, triglycerides, and smoking status become even more critical. There is little margin for error. Another issue that deserves attention is the aggressive lowering of LDL cholesterol in elderly patients. Some clinicians aim for extremely low LDL targets using high-dose medications or combination therapy. While this approach may be appropriate in younger populations, evidence suggests that in people over 75, very low LDL levels are associated with increased mortality. Extremely low cholesterol may impair immune function, negatively affect cognition, increase frailty, and contribute to muscle loss. In older adults, the benefits of pushing LDL to ultra-low levels are uncertain, while the potential harms are real. When aggressive LDL reduction is recommended later in life, it is reasonable to ask questions. Evidence should be specific to age, overall health, and the complete cholesterol profile rather than based solely on generalized guidelines. Stroke prevention is most effective when treatment is individualized rather than applied mechanically. Too often, treatment decisions are driven by rigid targets rather than real risk. An elderly patient with an LDL in the mid-80s may be pushed toward even lower numbers simply because guidelines recommend it, despite having strong protective markers and a low true stroke risk. At the same time, another patient with unhealthy HDL and triglyceride levels may receive little attention because one number appears acceptable. This misplaced focus leads to missed opportunities for prevention. One patient I treated illustrates this clearly. A 78-year-old man came to see me after suffering his second stroke. His first event had been mild and resolved, and afterward his LDL was lowered successfully with medication. His doctors were satisfied with the result. Yet years later, he experienced a much more severe stroke that left him with lasting weakness and speech impairment. When I reviewed his records, his LDL had remained well controlled for years. What stood out instead were persistently low HDL levels and severely elevated triglycerides. These abnormalities were never addressed. When I calculated his triglyceride to HDL ratio, it was extremely high, signaling profound stroke risk regardless of his LDL. Years earlier, targeted treatment and aggressive lifestyle counseling could have changed the outcome. His second stroke was not inevitable. It was preventable. This is why understanding the full cholesterol pattern matters. Preventing stroke requires a clear plan of action. Start by reviewing your complete lipid panel, not just total cholesterol or LDL. Pay close attention to HDL and triglycerides, and calculate the triglyceride to HDL ratio by dividing triglycerides by HDL. Write these values down and track them over time. Low HDL or elevated triglycerides signal increased stroke risk and deserve prompt attention. A high triglyceride to HDL ratio is especially concerning and should never be ignored, even if LDL appears acceptable. These markers reflect metabolic health and clotting tendency more accurately than LDL alone. Lifestyle intervention should be the first step. Meaningful weight loss, consistent high-intensity exercise, elimination of sugar and refined carbohydrates, increased omega-3 intake, reduced alcohol use, smoking cessation, higher fiber consumption, and moderation of saturated fat all work together to improve the numbers that truly matter. Applied consistently over several months, these changes can transform stroke risk for many people. If lifestyle changes are not enough, medication may be necessary. Treatment should match the problem. When low HDL and high triglycerides are present, therapies that specifically target these abnormalities deserve consideration. Patients should feel empowered to discuss these options and to ask whether the chosen medication is addressing their true risk. Genetic risk also plays a role. Individuals with a family history of early cardiovascular disease should consider testing for lipoprotein A, a marker not included in standard panels. While it cannot be easily lowered, knowing it is elevated allows for stricter control of all other risk factors. Aggressive cholesterol lowering later in life also warrants careful thought. When LDL is already low in older adults, pushing it even lower may offer little benefit and increase the chance of side effects. Treatment decisions should be individualized, especially when symptoms or quality of life issues arise. Cholesterol is only one piece of the puzzle. Stroke risk is influenced by blood pressure, blood sugar control, smoking status, heart rhythm abnormalities, physical activity, body weight, and overall diet. Addressing only one factor while ignoring the rest leaves significant risk untreated. Finally, stroke prevention is not a short-term project. The damage that leads to stroke develops over decades, and meaningful risk reduction requires long-term commitment. The habits and treatments that protect the brain must be sustained over time. One final misconception deserves correction. Many people believe that having a total cholesterol level below 200 automatically means they are safe. Unfortunately, that assumption can be dangerously misleading.